Good afternoon. This is the Oregon Health Authority for the June 25th webinar on mental health adult residential standardized rate implementation, which will begin next Monday on July 1st. Can somebody give us a chat response and make sure that folks can hear us? Around the room for presenting, we have
Kelly Knight with Contracts.
Judy Brazier.
Judy Brazier with Provider Services.
Elise Campbell, Adult Residential.
Elaine Sweet, Adult Mental Health.
Carmen Armendariz, Contracts.
So today we're going to go through a number of topics. A lot of this is somewhat a repeat of the webinars we've been doing since April. What we can do today is give clearer detail and definition to what we're proceeding with for July 1st. The first topic we're going to go through is how to bill and how to calculate your residential service T1020. Carmen will walk through that. We'll update on the phase out of the bundled rehabilitation rates. We will also introduce the detail around the new retainer payment, which was formerly the reserve service capacity payment. We'll have an update from Kelly on the behavioral health contract changes. We will review engagement and documentation requirements. And just a note on that, we will plan, there's been lots of questions, and I think this will be an ongoing conversation that we'll schedule a discussion on documentation and engagement later in July. We will review the criteria and requirements for the Tier 5 intensive services request. There was a provider notice sent out last week on this, and we'll go over that a bit more and also give you an update on the capacity reporting. All of those pieces are in flight for implementation next Monday. So I'm going to turn this over to Carmen and have her review the T1020 billing with you.
Okay, so the T1020 billing for the new standardized rate for Medicaid eligible individuals, we've already given everybody a letter with the rates for their individual homes, and it has the tiered rates 1 through 4. Also, before billing, you have to make sure that the resident is still eligible for Medicaid and has a current approved plan of care. And for non-Medicaid individuals, you must invoice the county for the standardized rates for non-Medicaid individuals. Make sure that the individual's acuity in their LSI is done by the IQA or by the county in the interim process that we get the IQA out. Be sure that when you set up the POC, you set it up with the correct tiered rate based on the LSI. And again, you could reference the letters that were sent to you at the beginning of the month for the tiered rates. Also, when you submit a claim, be sure that you submit with the new tiered rate, because as we've gone through the early adopters, some of them have experienced where they had to remove a claim because they put in the wrong amount or the old amount, and then they had to resubmit the claim with the correct amount. So that cuts into the time of payment. So the next slide is just a review of the residential plan of care when you enter into the
Whenever you get a chance, I was just going to give a couple of details. Go ahead and do that.
Into the MMIS system. As you could see, the service code is T1020. The dollars are the individual per diem rate for the tiered rate, and then you have your effective dates. Make sure that the dates for the plan of care are correct, and bill for the dates of service on or between the effective date and the end date. Sharon, you have something to say?
Yeah, this is Sharon. Just to remind folks, a specific piece that's going to happen, I have given the rates for the individual clients, the roster with the LSI that you provided on the June 6th. We've converted that and applied the rates for each individual person and sent that spreadsheet to Keypro. They are currently in the process of adding those. And it may take up until probably July 11th to complete it. What we learned, and I'm looking at my expert from Provider Services in case I misstep here, is that you need to bill your new rate for your dates of service July 1 and forward. Mm-hmm. It would be helpful if you check to make sure in the web portal that the rate's been changed. We're real comfortable on giving a cushion about it should all be done by July 11th. But regardless, you should bill at the higher rate. If you bill at the lower rate, to Carmen's point, the MMIS won't pay you any more than what you billed. So your total billed amount per day needs to be that new rate. And we actually calculated that and already conveyed that to Keypro. And so we validated all those pieces of it, and they're working through that. I know some people want to make sure that they can bill. It's a weekly financial. You can bill daily. It processes weekly. You should be able to bill by the July 5th is the Friday, the first week cycle. And the MMIS will catch up with you, even if you build at the higher rate and the POC hasn't changed yet. Keypro hasn't been able to get to yours. Once that rate is changed, it will cycle back in the next week on the 12th and correct it. Mm-hmm. So please proceed if you need to financially, if you're going to need to bill on the 5th. But I just wanted you to know we're in process. We provided that. So those are the ones we know of. Any new POC, please include the new rate, July 1, with that LSI that we gave you for the tiered amount. And if you have questions, we can go through it again, and I'm going to turn it back over to Carmen.
So billing the individuals per diem rate, we already, like Sharon said, the POCs are being updated with the new tiered rates. So based on the tiers, the LSIs for tier 2 is 40 or lower. For tier 3 is LSI score 41 to 60. For tier 4, it's 61 to 79. Now for the new tier 5 is LSI 80 or over, except for the SRTS and the YAP programs, which we already did an adjustment for their additional staff, so the tier 5 doesn't apply. So we've given you an example or two below for billing for a tier 3 and a tier 2 individual for July 2009. So for individual 1, their LSI score is 43, so they fall under tier 3. And for that specific home where that individual, their daily rate is $246.80. And the bill from and bill to service dates are 31 days or 31 units for the month of July. So it'll take that 31 times $246.80, and it'll equal to a total billed amount of $7,650.80. And the tier 2 individual 2, their LSI score is 38. The tier would be 2. And for that specific home, for that specific individual, the daily rate is $160.07. And again, the units they're building is for the month of July, which are 31 days. It's multiplied by the 160.07, which gives a total build of $4,962 with 17 cents. So on the next screen, we talk about the modifiers. This is just a refresher for the next two slides are just refreshers for the modifiers that you use. You would enter your modifiers on the left side of the POC where it says modifiers. There's 4 different locations, but there are individual modifiers that you would use, and they're the same, so I'm just not going to go over that because it's just a refresher. And now I'm going to turn it over to Sharon so she could talk about the rehabilitation services.
As you know, we have been phasing out the bundled rehabilitation services. So working with KeyPro, they understand that any authorized service authorizations for those bundled codes, the H2013, H2016, or H2018 that were approved in January, February, and March will be allowed to continue beyond June 30 to their expiration date. Any of the pending or new requests for those codes from April and May, KeyPro was approving the bundled code only through June 30, and then sending it back so that you would be requesting individual service authorizations for any dates of service July 1 and forward. So there'll be some folks that have those already authorized bundled. Those will continue for the 6-month period of time. And then you'll need to go ahead and go through the process of requesting the PA for the individual service codes. Everyone else, dates of service July 1, 2019 and forward, you've got to do the request for the individual services. We did clarify that this does not apply to the ECS, the enhanced care setting, in the DHS long-term care setting, and it also doesn't apply to PATES or PRTS. So hopefully that's clear. If there are issues still, you can email us and we'll help facilitate. But I think we're at the place where this is phasing out, except for those ones that were already authorized. We will go back. We found some that were authorized for more than 6 months, and we may reach out to you because we're going to only authorize those for a 6-month period. And there were some that were actually clear into 2020, but we can work that out later in the summer. Retainer payments, Carmen.
Okay, so next week. So one of the changes that we have beginning July 1st is the retainer payment process, which is the old reserve service capacity. So if you have a client that is Medicaid eligible, you will be able to bill for the retainer payment through MMIS. So this is for 30 days or less of temporary absences for medical or psychiatric reasons. You have to submit a prior authorization request using the provider web portal and using the code T2033 with a HK modifier and a HW modifier for individuals that are 1915I eligible. Specify the required number of days and attach the required documentation, which is the new retainer form, which we will be sending out to you as part of the package after the webinar, along with the procedure. So once the prior authorization is set up and the attached retainer payment form is with the PA, we will go in there and review your request and change the status to ready to review, and it'll stay in that status until the client returns and you fill out the client status portion section on the retainer form and upload it to the same PA when the client returns. So if it's approved, you can then bill the T2033 for the approved days at your facility's Tier 1 daily or per diem rate. If you don't know how to submit through the web portal, email the mentalhealth.residential transition email so we could get the training slides to you about the provider web portal. Now, it's very important that you provide us with a Medicaid ID, provider Medicaid ID on the form. There is a space for that on the retainer form, and we are going to start working with the early adopters to test this retainer payment. But again, if you need training with the PAs, let us know. So how to bill for the retainer payments for non-Medicaid covered absences. There is a change in that as well. for temporary absences for legal jurisdiction reasons, you need to contact the county to invoice at the Tier 1 rate, but you will be using the same retainer payment form, and we're requiring that to be attached to an invoice that you submit to the counties. And also for non-Medicaid eligible individuals, you will also be using the retainer payment form at invoicing at the Tier 1 rate for non-Medicaid individuals. Okay, now I'm going to pass it on to Kelly.
Hi, this is Kelly. I want to just add that we did a training yesterday for all non-OHP residential service payment and retainer payment needs. So I was informed this morning that the webinar and slides are now uploaded to our mental health rate page. So it's the same place that we've posted in the past to all. Oh, and it's at the end of this presentation as well. So I just want to point that out because it probably sounds like a lot. It sounds like a lot to me to have a kind of a two billing process for the same kind of payment. But I promise we'll get through it, and once we get used to this, I think it'll be pretty simple and a good process. So on to the next slide. So the changes for behavioral health contracts for CMHPs and for direct providers are that unlike in the past, the contracts beginning on July 1 are now going to be 18 months in duration, and that is really the same proportions of funding for the same services that you've had, with in addition to some dollars for non-OHP residential and for retainer. The only thing that is going away is aid and assist for invoicing.
But to clarify, aid and assist funding is also coming at a little different amount of time. So the aid and assist is for 6 months instead of the 18, the service element.
Thank you.
Okay.
So adult mental health residential services related service elements are service element 26, 27, and 28. These are replacing your slots in SE20 for rent subsidy. This is really written weird to me. Sorry. We've moved enough funding into contract to take care of the non-OHP, but all of the funding has been resourced or reallocated through the Medicaid payments. And so I've already kind of mentioned invoicing. The Part C invoicing replaces cards. There will no longer be cards for non-OHP eligible people that need residential service coverage, and as well as non-OHP eligible that are temporarily out of the home and need a retainer payment.
Okay, residential treatment services. This is Elaine Sweet. We want to talk a little bit about the engagement and documentation requirements. So the direct care active engagement is the work that the direct care staff do for mental health residential treatment facilities or homes to support the personal care and habilitation for an individual's activities of daily living or instrumental activities of daily living. This active engagement can include individual or small groups, the staff providing the habilitation services. The engagement excludes an individual's rehabilitation treatment and services. There are, for licensed and certified staff performing rehabilitative treatment, the implementation of an individualized care plan developed under and supervised by a physician and other qualified mental health professionals that prescribes
specific therapies and activities for rehabilitation. So we're just trying to delineate between the two types of service someone might be getting. The in-home active engagement is really around the personal care, and then the licensed certified staff are doing more of a rehabilitative treatment.
And Elaine, some of the questions that providers and early adopters posed over the course of the last 6 months or whatever is, in the licensed rehab setting, they have to clinically document per encounter. And it's distinctly different in the direct staff engagement, where it's we're looking for average hours of engagement across the day and the shift that can be cumulative in nature to make sure that based upon the tiered LSI, the acuity need of the client, that the direct staff is able to work with the individual based upon their person-centered service plan. So that was the other reason to kind of juxtapose those two, if that makes sense.
Right. So, so there is a different expectation for documentation that we'll be talking about shortly. So engagement versus supervision hours. When we talk about active engagement, we're saying that's provided by direct care staff to support personal care and rehabilitation, including activities of daily living and instrumental activities of daily living. Active engagement may include an individual or small group staff providing rehabilitation services. So one of the examples that I've been giving is when we work with individuals to help them with self-care, room care, those kinds of things. That's when we're engaging with clients. And then if we're providing a meal and individuals are helping with cooking that meal, then you have several individuals together working on meal prep, menu planning. These are all types of engagement that you can consider as time that you've spent with individuals. For supervision, every individual needs to have supervision throughout the day, and these are more passive compared to the active engagement hours. Supervision is always available. Engagement is on an individual basis, and it's by need of the individual. Individual acuity and hours of engagement. Yeah, next slide. So individual acuity is used to determine the allocation of active engagement and supervision hours in a billable day to foster a person-centered system supported by the HCBS requirements, or home and community-based service requirements. So individuals who have a fairly low LSI, low acuity, we're anticipating an average of 3 hours of active engagement daily. For medium level of need, we anticipate an average of 5 hours of engagement daily. And then for high level of need, the individuals may need an average of 7 hours of active engagement daily. This doesn't include the high level of need individuals who are considered tier 5, where we are expecting potentially 9 hours of engagement, active engagement daily for someone who has really significant needs. Then we have the golden thread. So what's important about this is that when we talk about Medicaid payments and billing and the requirements involved, it really starts with the individual and what their needs are. So we really want to look at what their person-centered plan identifies as their needs. It comes off of an assessment that's not listed here, but that assessment is, oh, okay, there it is. So the person-centered plan is actually what they work with the individual on to determine what their needs and their desires are. The LSI is where we get the really specific needs of engagement, whether the person has complete need of active constant supervision, or whether they can have some independence or they can do some things completely independently. So the LSI or the locus gives us that information. Then we complete the assessment, which identifies the diagnosis and the need for the service, and then it goes to the service plan, which the service plan is actually the identified treatment and activities that are needing to be provided on a daily or monthly basis. And then we have a daily documentation requirement that identifies the progress notes for an individual. There's another part of this slide. So with the person-centered plan, we want to look at personal goals, preferences, and interests. And then with the LSI, we're looking at ADLs, which include hygiene, medications, feeding, ambulation, and toileting. The incidental activities of daily living, which include finances, meals, cleaning, transportation, appointments, legal, social, and recreational. There's psychosocial skills, which include managing symptoms and risk towards self and others, impulsiveness, disorganization, emotions, communication, and co-occurring disorders. Then services and supports needed, including modifying the environment, routine, or staffing, line of sight supervision, or one-on-one support, supervision, and monitoring. And I'm not sure who I'm handing it off to next.
If you want to tag team with me, I'll go through the permanent rule and the intensive services.
Okay.
When we sent out the provider notice last week about the Tier 5 intensive services criteria, we also gave you a draft of the rule change we were going to make to include it in the permanent rule that happens at the end of this week. What we want to recognize is that there is a Tier 5 for, as Elaine called it professionally, the high level of need, where it requires pretty much frequent throughout the day monitoring and redirect because of the complications of multiple medical, psychiatric, cognitive, behavioral conditions. And that if the assessment, the acuity assessment of LSI is 80 plus, that's one level of Tier 5 rate, and that's straightforward. And those rates are already plugged in for the information we gave to KeyPro. There's a second level where the assessment may not have adequately captured the effects of those complicating conditions and situations that are severely interfering with treatment and self-care. And so in those instances, we've created this process where we're asking providers to facilitate with their CMHP a request to us for an intensive services review. And we will expedite those as best we can going forward, but the memo we gave you last week, and this information is basically from that memo. We're requiring an extensive list of documentation so that we can see where the LSI might not have included it, how severe the conditions are, what the duration and frequency is, and that sort of thing. The piece that is expected of either Tier 5, whether it's 80 plus LSI or this intensive services situation that we would review case by case, the expectation of frequent monitoring and redirect assumes that somewhere between 7 and 10 hours a day, there's some kind of an engagement or an interaction with the individual. So again, the documentation would need to reflect that. The request for these intensive services, please send it to the mentalhealth.residentialtransition email box, and we have a weekly committee meeting to review those requests along with a number of other issues. So the next slide is literally the set of documentation that we put out in the notice. Get that to us as quickly as possible so that we can look at those. If there are situations we want to be timely and responsive, but we also need to make sure that it meets the criteria. I would say both of these are still within the rate standardization. The Tier 5 itself, the 80 plus LSI, and the fact that there might be justification for someone's condition that qualifies still allows us to use the standardized rates. So I'm sure we'll keep working through that and see what kind of trends we see, what kind of information and clarity we can get over time working with you on these. Just to reinforce, and the next slide is around the administrative rules. We thought we were going to have to do a temporary rule because of this criteria add, but we've been told by the Medicaid program that all of this can be rolled up. We had Department of Justice look at it, at the rules, and those will all be incorporated into the rule that gets finalized and made permanent this Friday, the 28th. So I gave you references on the rule slide where you can find those. And I also want to call out to folks that we also have a pending set of rules from the Medicaid programs for home and community-based services. And so that will be another one for folks to pay attention to, and we may have future discussions about that. I'm going to turn it back to Carmen, and we're going to talk about capacity reporting.
So we are asking that all our providers report to us weekly what their capacity is. A facility-specific roster with any LSI changes, which means new admins, LSI changes on a client, transfers, discharges, or if you don't have any changes at all. We've set up a new email. It's abh.residential capacity reporting, and there is also a form. It's in Excel. If you could keep it in Excel and submit it in Excel, that would be great, because if you send it in a PDF form, then we just have to retype all that information, and that's not a good use of our time. So in the template that you receive, there are 2 tabs. One has thorough instructions, you know, using the drop down, what it means to enter, what it means to select. And every client should be included, both the residents and those being referred for each residential setting. So there is a new version that is dated June 7, 2019. If you need that new form, please email the ABH Residential Capacity Reporting email box so we could get that new form to you.
And we also, just to note, when we sent out the provider notice on the intensive services, Tier 5 intensive services request, we sent out the newest version so that people have that, replace that. And I also wanted to just call attention to we now have 2 email boxes, and we're going to transition operationally the capacity and the retainer payment and those sorts of things are going to go through the ABH Residential Capacity Reporting email box, so that on an ongoing basis, the team is going to be able to work through and coordinate their information. The specific things that are still coming to the mental health residential is if you still need training around, like, say, the retainer payment process because you haven't done prior authorization in MMIS before, and specifically the intensive services requests. If you can't decide, we will coordinate here, but we are shifting most things so that the entire team can be able to coordinate the information. We're using the ABH Residential Capacity Reporting email going forward. We will coordinate internally, so don't worry if you get it to one or the other. There's not a wrong door. In terms of, we put in just the billing resources just to remind folks. And then I added a couple of things on the next steps for July through December. What we are planning is to have several, it seems like at least a monthly call. You know, we can share some information like we do on the webinars and then make it kind of the chat exchange of information so that we could stay in touch with things. That probably it's going to lend itself maybe to a question and answer. We haven't been as timely and able to respond with a Q&A up on the website because the answers have been coming we've had to work through them with you. But I think that things are pretty settled now with the rule that we can do that. We talked internally this week that we want to start doing site visits and technical assistance potentially in August. So I don't have any more information, but that was the team wanting to say, how do we proceed on that? In addition with the provider calls and the site visits, we would like to work with providers in the association to facilitate some best practices sessions. There's a lot of work and a lot of understanding the system improvements that we're all trying to accomplish, including those from the provider side and the association, as well as OHA. So we want to work collaboratively as we go forward on this, and hope that those kinds of sessions will be an opportunity for us to have those conversations. So I think Carmen is ready to walk through some questions for us. No pressure, Carmen.
I can hear you, I can hear you, yay, okay. Were there any handouts for today? We'll be sending them out.
Yes.
One of the questions, are the authorization periods now 12 months instead of 6?
So my understanding of plan of care, 1959 authorizations continue to be 12 months.
Yes.
Okay. Elaine says yes.
For out-of-county placements, i.e. a Jackson County resident is placed in a Clackamas County RTF, would the RTF provider be invoicing Jackson County or Clackamas County?
Clackamas County.
Clackamas County would invoice for the individual. It's funding that goes into contracts for non-OHP is based on individuals being served in that county, not where they came from.
Will SRTF still authorize for 90 days, not 365 like RTF?
I think they're 6 months, but we'll have to clarify.
Okay.
Yeah.
I think they're 6-month authorizations.
How do we bill for absent days? We already reviewed that.
We would refer you to the retainer payment section of the webinar.
Is there anything changing about the rules related to leave of absences?
We are going to change the rule to match the retainer payment. Substantively, I don't think there's going to be significant changes to the language, but that will be coming.
Is there a deadline for this to be sent in for RSCPs? There was a very limited time span within which to do so. You have to submit a PA and the retainer payment form within 2 business days of the start of the absence.
So can I ask a question about that?
Yes.
If retainer payment request is sent, let's say on the 6th day, it would start from that day, and the prior days would 2 business days prior.
Yeah.
Okay.
Yeah.
So there wouldn't be a complete cutoff. It would only be that you didn't get the full 6 days. You would get 4 instead.
4 instead because
Okay.
because they didn't submit it within the 2 business days. Then
Okay.
due to the OAR language, the way it's stated, the
Right.
couple of days do not apply.
Okay.
But the PA will not be deleted, you know, it
Okay.
would be left in place. But, you know, the authorization would only be for the one submitted timely.
Okay.
Megan Major, I'm still waiting for RSCP payments that happened during the last 6 months. I have not gotten paid for them. Megan, we will be contacting you because we're going to ask you to test our retainer payments PAs in MMIS. So we will be contacting you soon. Thank you for the reminder.
So the good news is, in the future, these will either be paid through MMIS with your normal payments, or they will be paid through the invoicing process, which, for those of you who are familiar, basically for anything that occurs in July, you would bill us by August 15th, and then the payment to you or your agency would be following in the next few weeks.
And actually, the 2 business days, correct me if I'm wrong, is actually more time.
It's more time
because it used to be 48 hours.
48
so we want to
hours.
make sure that folks who might not have access to MMIS or otherwise be able to submit, that you have the time to do that.
Yeah, because not everybody works on the weekends, I found out.
Okay.
It looks like Janelle's asking a question about rental assistance billing.
Yeah.
That's not the topic of this discussion.
Yeah, this is really about residential, but Janelle, feel free to email me questions about rental assistance. This is Kelly.
How will the PCP and LSI work for community-based referrals that don't originate from the state hospital?
So the LSIs that don't come from the state hospital initially, if you can get the independent qualified agent to come and do those, that's great. If you can't, the county mental health program can do them for now. And then, what was the rest of the question?
Oh, sorry.
So you can get the county mental health program to do the LSIs, and then the independent qualified agent can come and do the PCP when they're available to do so.
Is the required documentation needed if the individual's LSI is 80 or above?
No. Other than what's required to,
Correct.
okay. Not the additional documentation isn't required.
Yeah. Kipro has not completed the PCPs for my clients within our residential program. What is method by which providers can obtain a Tier 5 rate if the PCP has not been completed? As it is integral to at least 2 pieces of the required documentation.
I think this is Elaine, I'm going to say that we want you to send in as much of the documentation that you have, and I think just with an explanation that was not completed by the IQA. And we will have to take that into account when we look at the rest of the record.
Yeah. Will a template be provided for the letter from the CMHP affirming need for services? If a template is not provided, will additional guidelines or explanation of what is being requested be provided to the county?
For the invoicing process?
No, this is for the intensive services.
One-page synopsis from the CMHP for
I think it's a written.
It's just a written letter or email from the county. There's no template for them to provide that.
This is Sharon, and understand that right now we're in that place where the IQA is not yet able to complete the person-centered service plans and the acuity assessments of everybody. So as we do this transition, which we're going to coordinate with you all and with the CMHPs, we're expecting that the assessments and this kind of synopsis that CMHP is involved in validating the intensity of need, the acuity assessment for the clients that are in that area and for those programs. So that shouldn't be a new ask, and that they're already involved in that piece of it. I mean, literally everything that was submitted for the June 6th rosters to be able to move the race forward had the CMHPs reviewing and or performing the assessments. So we're hoping that that's straightforward. We can certainly take that up with the committee, but there's not an intention to provide a template.
Next question, how often are LSI scores change? How often are LSI score changes that change a tier level to be addressed or approved in the MMIS system for billing changes?
So what we originally talked about and what's in rule is if you have a significant change in the client functioning that remains over 30 days, you can ask for a adjusted LSI, and if it's determined that the LSI change that occurs is a significant increase in if the number significantly increases enough to change the tier level, then that would be what we would accept. But it's a 30-day window of looking at an individual whose functioning has significantly changed. In some cases, it may not be that their LSI would increase over, for example, if they're at 42, they may not get over 60 to be a tier 4. So you would want to be looking at whether that is a significant change for that individual or not.
When billing on the security invoice for non-Medicaid, do we bill tier 1 in addition to the individual service offered to that person?
Yeah, so security is actually its own thing for PSRB. So that remains, but for a non-OHP person in residential, that's PSRB, you would request the service payment using Service Element 28 invoice. Actually, it's in an Excel workbook, and you would use that format for the service payment or the personal care.
And it's based on the person's LSI, the tier that you would be billing.
Yes.
Yeah. For non-OHP, yeah. Right now, POC authorizations are sent to KEPRO. Where are we going to be sending them starting July 1st?
So for now, they'll still be going to KEPRO.
That's not changing.
There is a contract out for the independent qualified agent, and that will not be resolved until approximately the end of the year. So December 31st, we would certainly let you know if that changes sooner.
Okay. Brad has a lot of questions. Okay. As new rates are expected to take effect in less than 1 week, will there be a method by which providers will be able to retroactively take advantage of the Tier 5 rate, assuming they are unable to gather required documentation in a timely manner? For some of our residential programs, the difference between a Tier 4 and Tier 5 rate for even a single month could be detrimental to their sustainability. If providers are not able to retroactively receive Tier 5 rate, how soon after OHA receives necessary documentation will Tier 5 rates go into effect?
Well, we're going to work with folks and be as responsive as possible. The documentation needs to indicate that someone's condition has continued in that duration and that period of time, and
They should be able to retroactive.
we should, I mean, there's not a prohibition against doing retroactive.
To July 1st.
Yeah. If, it goes out, I mean, the MMIS and Medicaid allow for claiming up to a year. I would think if it's financially problematic for y'all, the documentation would become problematic. So,
But this change is only from July 1 forward, because they have been provided funding in the prior
Correct.
timeframe.
And my year timeline, as I look across to provider services to my friend Judy, is that some people, I don't want the delay to be any longer than a year, because then we can't go back.
Yeah.
So if by the end of next June, we don't have that documentation, it would be pretty hard to document retroactive to this July.
Yeah.
That was my point.
And I don't think, I hope that's not what we're talking about.
What will be the consequence if active engagement hours aren't met?
So our goal is that everyone is going to be learning and building up to that. So we have a 6-month window where we're going to be helping people understand what that engagement is and improve your engagement activities that you provide. And I mean, I don't at this point see that our goal is not to provide consequences, but to provide encouragement and technical assistance so that we can help you get to where you need to be.
If an out-of-county placement doesn't have income, does the placement county process the invoice for room, board, PIF?
Yes.
Yes.
That process doesn't change. When sending the new prior authorization, do we need to submit a whole packet or just upload a new fee for service sheet for their current MMIS authorization?
It's the plan of care that they're going to be needing,
Yeah.
and whatever requirements they have that go with that.
But potentially they're talking about PAs for rehab,
Oh,
but by the wording.
Yeah.
if it's prior authorization for treatment is, you would submit the prior authorization request and then whatever documentation is required to go with that.
Yeah.
And it would be for individual therapies as opposed to a per diem rate.
Yeah. All right. Do we send in the retainer form like usual and then enter the PA in MMIS, or is how we turn in the retainer form changing? So for a Medicaid eligible client, you have to create the PA first, and then there is an attachment document option at the bottom of the PA where you would attach the retainer payment form. So that is changing for a Medicaid eligible client. None of the retainer payment categories fit the situation where our YAT clients are staying with the family.
Nope.
Nope. That's correct. How will the IQA be conducting the LSIs and PCPs? Will they be meeting with the individuals face-to-face?
That is the goal. We are encouraging them to meet with the individual client and the group, the facility staff, so that they get the full picture of the client's needs.
If a resident is already out of the facility starting in June, how do we start a retainer payment beginning July 1? Do we start from the day they left in June, or start as of 7/1? So for the retainer payments are effective July 1st, 2019. Prior to that, you will still use the old process of the reserve service capacity payment, which we also maintain documentation form. So the portion of June will remain as the old process, And as of July 1st, it will be under the new process.
So the IQA is currently the company called Kepro, and we are in the process of going through an RFP, which is a request for proposal, and that's not final yet, so we don't know who the new IQA will be, but they will be in place by January 1 of 2020.
Next question. Who is responsible submitting the PAs for individual services going forward, the CMHP or the provider? Currently, our CMHP is submitting our H2016 PAs.
So who is, it depends. I mean, Elaine, if you can speak to some of this. If the rendering provider should be billing unless they have if the CMHP is representing that rendering provider, then they may still be the one submitting the PA. It depends on who is actually performing the service and who is billing for that service, which is probably the reason the CMHP is submitting it in the first place. Yep. And we're at 2 minutes or so, so we'll just take this as the last question and we'll have to get back to the rest.
Okay. So last question, or for clarification, Kelly, you said for service payment on PSRB non-Medicaid resident bill on invoice tracker through SE28 tab, if it's a non-Medicaid eligible PSRB client or non-Medicaid eligible service for the PSRB client, you invoice through the invoice tracker.
Yeah, so I think to make it a little more clear, for the additional invoicing pieces, we are creating 28 residential workbooks in Excel. So for PSRB, you're going to be billing for them in 2 separate veins. You're going to be invoicing for them on your regular, for the last 4 years workbook in 30 for security and then any additional supports that they require. And then for their residential service payment, you will use this new workbook in Excel in 28 for service element 28 Part C dollars for their residential payment.
If the client isn't Medicaid eligible.
Yes, as long as they're not Medicaid eligible.
All right, we have some more questions, but we're running out of time.
So the pieces, we'll look at these questions and push out responses if they're general for the whole group or not. The pieces that we would want, we will send out the slides. We'll get the recording put up on the website. I will resend the intensive services information out to folks, and also the retainer payment form and procedure. What we can probably do, and I'm looking at Carmen, we have a training packet for people about how to submit a PA around that's related to retainer payment. We could load that onto the website as well for folks. And then we're specifically going to reach out to the early adopters and the group of people we've identified who haven't used the MMIS prior authorization before. If you do want specific one-on-one help, give us an email, but otherwise we're going to reach out and make sure that the training's on the website, you can look at it, and if you figure it out, great. If not, give us an email and we'll step in and help you. But the early adopters, we'll work through the ones that you have submitted as soon as possible, and I plan on giving you an email this afternoon. Anything else from people?
No.
Thank you very much, and we're all excited. Invoice tracking is going to be very exciting. The standardized rates we're excited about, and we couldn't have got there without you all giving us input and giving us your information and sharing, and we look forward to working with you and providing technical assistance as we go forward.
Thank you, everyone.